Hello, I'm Alice Sadie, Research Extraordinaire, and today we are delving into the world of surgical site infections, where I will present to you the current situation, what the current evidence suggests, the gaps in professional practice, and what can be done to overcome the existing challenges in effectively preventing surgical site infections. To start us off, let's have a look at what constitutes a surgical site infection. The Centre for Disease Control and Prevention, also known as the CDC, defines a surgical site infection as an infection that occurs in surgical patients at the incision site within 30 days after surgery. The CDC subcategorizes surgical site infections into three classifications. 1. Superficial incisional SSIs, which only affect skin and subcutaneous tissue at the site of incision. 2. Deep incisional SSIs, which affect deep soft tissue like fascia and muscle layers. And 3. Organ-space SSIs, which affect any organ or space between organs operated on during surgery. Now that we know what a surgical site infection is, let's discuss why this is a topic of discussion. It's been estimated that 312.9 million major surgical procedures are performed annually worldwide. Surgical site infections are one of the most common yet serious complications affecting up to a third of patients post-operatively. After pneumonia and urinary tract infections, surgical site infections are the third most common hospital-acquired infections. The research papers stress the extent to which SSIs can have a serious impact on the patient and hospital. These include prolonged hospital stay, reduced quality of life, increased mortality, additional costs for patients, and rising healthcare costs due to additional therapeutic treatments, further surgical procedures, rehospitalizations, or intensive care unit admissions. Each SSI is associated with 7 to 10 additional postoperative hospital days, and patients with an SSI are 2 to 11 times more at risk of death compared to patients without an SSI. In the recent years, the importance of prevention and control of SSIs has been widely recognized, particularly with the rise of antibiotic-resistant bacteria. Now it's time for our segment called Are You Susceptible?, where I point out some of the internal risk factors that could influence your susceptibility of getting an SSI. One of the big factors which really increases your risk of getting a surgical site infection is diabetes mellitus. The reason this is so is because of the pre-existing complications of chronic hypoglycemia, including vascular atherosclerotic disease and peripheral and autonomic neuropathies that will impact wound healing. Obesity is another factor which is associated with increased risk of SSI, mainly because of the comorbidities which often go hand in hand with obesity, like diabetes mellitus. On the other hand of the spectrum, malnutrition is also a major risk factor because people who are found to be malnourished often have a depleted immune response to infection. Serum albumin is generally what is used to detect this. Cigarette smoking has been associated with inhibited wound healing and decreased circulation to the skin due to microvascular obstruction from platelet aggregation and increased non-functioning hemoglobin, and this increases one's risk of developing a surgical site infection. Finally, you have an increased chance of developing an SSI if you have a pre-existing remote body site infection, basically an infection in any other part of your body at time of surgery, like a dental or urinary infection, and this is because it can become a site for bacterial transfer. These infections at a site remote from the wound have been linked to increasing SSI rates 3 to 5-fold. There are some external factors that influence your risk of getting an SSI, and one being the length of surgery. An operative duration of longer than 2 hours has previously been reported to be associated with SSI due to the increased duration of exposure to microorganisms in the operating theatre. The risk of infection varies by type of surgical site, incision site. The traditional wound classification system designed by the CDC stratifies the increased likelihood of an extent of bacterial contamination during the surgical procedure into 4 separate classes of procedures. The first is clean. The wound is considered to be clean when the operative procedure does not enter into a normally colonized viscous or lumen of the body. SSI rates in this class of procedures are less than 2%. Next is clean contaminated. A site is considered to be clean contaminated when the operative procedure enters into a colonized viscous or cavity of the body under controlled circumstances. SSI rates in this class of procedure range from 4 to 10%. A wound is classified as contaminated when gross contamination is present but no infection is obvious. SSI rates in this class of procedures can exceed 20%. And finally, if active infection is already present in the surgical site, it is considered to be a dirty wound. SSI rates in this class of procedures can exceed 40%. Now, what is the current situation regarding practice in surgical site infections? An article by Worth et al. Conducted a study in 2015 that looked at 183,625 surgeries between 2002 and 2013. They evaluated the time trends in SSI rates and pathogens in 81 Australian healthcare facilities participating in the Victorian Healthcare Associated Infection Surveillance System. 5,123 SSIs were reported. Staphylococcus aureus was the most frequently identified pathogen, and a statistically significant increase in infections due to ceftriaxone-resistant E. coli was observed. The World Health Organization recognized this statistic in their Global Guidelines for the Prevention of Surgical Site Infections published in 2016, as an indicator that SSIs are a large issue in both developing and developed countries, with Australia having an SSI incident rate of 2.8%, which is only slightly better than lesser developed countries like Chile and Uruguay, who have far less access to the advanced level of technology and resources available to us. Why is this happening? With the copious amount of research out there, it was extremely surprising to me what the systematic reviews conducted by the Cochrane Library, which are all level 1 evidence, concluded with, and that was something that shocked me. The systematic reviews conducted were regarding the various practices that registered nurses and other perioperative staff implement to minimise the risk of SSIs. All but one concluded that the level and quality of evidence supporting our current practices was so poor, and that further high-quality research is crucial to provide a solid rationale for these interventions. The World Health Organization Global Guidelines for the Prevention of Surgical Site Infections, when discussing recommendations for practice, concur with the conclusion deduced from the systematic reviews from the Cochrane database regarding the very poor quality of evidence that supports our current practice. Additionally, some of the research highlighted the lack of an appropriate, consistent surveillance system to monitor trends in SSIs within hospital environments and the absolute need for it in our hospitals in order to more efficiently minimize the incidence of SSIs. The study by Worth et al. Supports this notion through the results that they gathered, which note a significant decrease in the incident rates of SSIs in Victorian hospitals over 11 years with the implementation of a surveillance system. The reduction rate per year was 11% for superficial SSIs, 9% for deep SSIs, and 5% for organ-or-space SSIs. The Cochrane database is a home to an array of systematic reviews which cover the various interventions currently being implemented in hospitals to prevent SSIs. They covered surgical hand antisepsis, preoperative showering with antiseptics, topical antibiotics, perioperative glycemic control regimens, wound dressings, and the use of plastic adhesive drapes during surgery. This is what the studies concluded. Could find no evidence that adhesive drapes reduce SSI rates and some evidence that they may even increase infection rates. There is insufficient evidence to support whether covering surgical wounds reduces the risk of SSIs compared to not using a dressing, or whether any particular wound dressing is more effective at reducing the risk of SSIs. Based on the current evidence, decision makers may wish to base decisions on patient preference and cost. There is insufficient evidence to support strict glycemic control versus conventional management for the prevention of SSIs, and studies were limited by small sample size and inconsistencies in methodological quality. Topical antibiotics probably reduce the risk of SSI relative to no antibiotic. The review provides no clear evidence for benefits of preoperative showering to reduce surgical site infection. Efforts to reduce the incidence of SSI should focus on interventions where effect has been demonstrated. Generally, almost all evidence available to inform decisions about hand antisepsis were informed by low or very low quality evidence. There is a large aspect of our practice that requires further high quality research about the most effective interventions to prevent SSIs. So how can we fix this? The most essential thing required to improve our quality of care and SSI prevention intervention techniques is through the conduction of larger sample size studies that contain evidence of a high quality that can support or improve current practice and discover more efficient ways to prevent patients from developing SSIs. Additionally, the implementation of appropriate and consistent surveillance systems within hospitals to monitor trends and occurrences of SSIs and assist in determining the root cause of SSIs in the current healthcare setting by analysing the collected data and transforming policy and practice accordingly. And the aim of all this? Delivering safe practice and achieving patient outcomes through the provision of high-quality care. These solutions reduce or eliminate the barriers to improving the quality of care regarding the prevention of surgical site infections and promote evidence-based practice being implemented in the clinical setting. We still have a long way to go with our research and the need for high-quality evidence randomised studies to provide a solid basis for our surgical site infection prevention interventions. And the result of this, hopefully a dramatic difference to patients' post-operative experience. I'm Alice Sadie. Thank you for listening.